Now I invite Dr. Swanand, our showstopper. Please go ahead.
Well, respected chairpersons and respected consultants, very good afternoon. I would like to thank organizing committee MENCON for this opportunity. And today my topic is Nystagmus patterns you must know in vertigo. So, few points regarding nystagmus. Nystagmus, it's an involuntary rhythmical oscillatory movements of the eyes. It may be horizontal, vertical or rotatory. Vestibular nystagmus has got a slow component and a fast component, and the direction of the nystagmus is indicated by the direction of the fast component. Intensity of the nystagmus is indicated by its degree. For understanding nystagmus, we must know two laws. First one is Alexander's law. It states that there is an increased frequency and amplitude of nystagmus with gaze in direction of fast component, and there is a reverse effect with gaze opposite to fast component. There are three grades. Grade 1, nystagmus only in the direction of the fast component. Grade 2, nystagmus primarily in a gaze position, and grade 3, nystagmus evident in all positions of eyes. There is one more important law called the Evalt's law. It can be divided into three types. First law states that the direction of the nystagmus is directly correlated to the canal being stimulated. Second law states that the fluid flow or otoconia moving towards the cupula in the horizontal canal is an excitatory stimulus. And third law states that fluid flow or otoconia moving away from the cupula in vertical canal is excitatory. Thus, excitation of any canal creates a greater response than inhibition. Now, nystagmus from central lesion, we all know that there is no latency period, duration more than 1 minute, no fatigability. It's a direction changing nystagmus, does not suppress on visual fixation, means on opening of the eyes, and mostly it is vertical. Nystagmus from peripheral lesion, latency period is around 2 to 20 seconds, duration less than 1 minute. There is fatigability. Its direction fixed towards the undermost ear. It follows the Alexander's law, means unidirectional, and it also follows the Evalt's law, means excitation is more than inhibition, means in vestibular hypofunction it is intact ear, and in BPPV it is involved ear. Suppresses on visual fixation, means on opening of the eyes, and mostly it's horizontal. Now, all the tests in disc halpike, we get upbeating, torsional, rotatory, levo or dextro nystagmus. In supine roll test or macular Pagani test, we get a geotropical or apogeotropical nystagmus, and in modified disc halpike test, we get a downbeating nystagmus. So why we get this type of nystagmus in every case? Because there is a pairing of canals of extraocular muscles. In posterior canal, there is a pairing of ipsilateral superior oblique and contralateral inferior rectus, which causes rotatory and upbeating nystagmus. In lateral canal, there is a pairing of ipsilateral medial rectus and contralateral lateral rectus, which causes horizontal nystagmus. And in the anterior canal, there is a ipsilateral superior rectus and contralateral inferior oblique, which causes rotatory downbeating nystagmus. Now, these are all videos one by one, and there are total. So, this is a case recovering from vestibular neuronitis. You can see there is a left-sided nystagmus, and this right side is affected. On the right side, there is nystagmus is reduced. So it is following the Alexander's law.
This lady has come with a left ear tinnitus, and on examination of nystagmus, you can observe the spontaneous nystagmus, which is a left beating nystagmus, where the fast component is on the left side and slow component on the right side. You can very well observe it. ताई डावीकडे बघा. So on left gaze, it has increased.
Amplitude is increased.
सरळ बघा. It is decreased. उजवीकडे बघा. It is slow. परत सरळ बघा. सरळ. It is there. परत left side ला बघा. See, intensity is increased on the left gaze. Okay. Thank you.
The third one is a disc halpike test, right lateral, and you can very well observe in a slow motion, upbeating, levorotatory, anti-clockwise nystagmus.
Anti-clockwise upbeating torsional nystagmus, fatigue जवळ. कमी झाली?
So there is a latency, there is a fatigability, and when you get the patient up in disc halpike, it's a direction changing, means levorotatory becomes dextrorotatory. I will show that. So taking up, see, the anti-clockwise become the clockwise.
Anti-clockwise become a clockwise.
So this is a typical characteristics of
Nystagmus. You can very well see.
peripheral nystagmus.
सर मी आहे, काळजी करू नका, पडून देणार नाही तुम्हाला.
You can see nystagmus with the naked eyes.
डोळे उघडे ठेवा.
After latent period, it has started.
आणि जोरात आहे. मान रिलॅक्स ठेवा, खाली ठेवा, डोळे उघडे ठेवा, घाबरू नका, पडून नाही देणार. So it's a robust nystagmus, rotatory upbeating, anti-clockwise, and now it is fatigable. थांबली, बरोबर आहे, कमी झाली, पूर्ण कमी झाली की सांग. स्टॉप.
It's a McCure-Pagini test after
चक्कर यायला लागली, बरोबर आहे,
latent period.
घाबरू नको, घाबरू नको.
It's a geotropical nystagmus beating.
See, on McCure-Pagini,
right
it's a
side.
right beating horizontal geotropical nystagmus on the right side. So it's a right lateral canal affected. It has got a latency and it has fatigued. It was robust initially and fatigued. थांबली चक्कर, बरोबर आहे?
Yes.
Thank you. So we are doing a McCure-Pagini test, supine roll test, and I am expecting the apogeotropical nystagmus in this case.
Away from the ground.
डोळे मोठे ठेवा.
Fast component is away from the ground. It is not
You can
that
see the
robust. I got one more video
nystagmus.
which shows the robust nystagmus.
Right beating nystagmus away from the ground. It's an apogeotropical nystagmus when the head turned to the left side. Stop.
One more, this is modified disc halpike test and it's a down beating nystagmus.
डोळे उघडा. So this is a classical down beating nystagmus.
So it was anterior canal was involved.
This is down beating nystagmus. Stop. चक्कर थांबली, बरोबर आहे? Stop. Patient.
Again on the left disc halpike,
Patient
I got a down beating nystagmus. So that was a right anterior canal was involved. It's a classical, you can see with the naked eyes.
Right anterior canal BPPV. डोळे उघडे ठेव. चक्कर जास्त येते का ग? हां?
So on the left disc halpike
आणखीन जोरात आली, बरोबर आहे?
was down beating. So the canal involved was right anterior canal. It's a robust apogeotropical nystagmus. Robust.
चक्कर येते जोरात,
All know
बरोबर
that
आहे?
when it is
So it's a
apogeotropical, the otoconia are in the anterior limb of the horizontal canal,
on left
and
rotation.
when it is a geotropical, otoconia are in the posterior limb of the
right beating
horizontal
horizontal
canal.
nystagmus. It's a apogeotropical. It's a apogeotropical nystagmus opposite to the head turn. See, it's
So
a
this was a
classical positive fistula test.
fistula
And
test.
the patient is pressing on the
Tragus.
tragus. You are getting nystagmus. Okay, and this patient has been operated 20 years back, and since around 2 to 3 years, he is getting such symptoms that pressure on the pinna. चक्कर जास्त वाटली का?
It's a rebound nystagmus
उजवीकडे
for
पहा.
cerebellar stroke.
उजवीकडे पहा, उजवीकडे.
You
It's a
have some
rebound
more,
nystagmus.
उजवीकडे पहा.
Swanand, you have
उजवीकडे पहा,
more videos?
उजवीकडे.
Yeah, 2 videos more. It's a pendular nystagmus in multiple sclerosis. So only 1 minute, 1 to 2 minutes.
We're already running. Okay.
It's a pendular nystagmus and right Bruns nystagmus. It's a very interesting case. This patient came to me. He was roaming for
Left.
6 months, and if you see, there is a very fine coarse nystagmus with a high
Right.
amplitude on the left side and a fine nystagmus on the right side. It's a direction changing, and I immediately told him to do the scan, and it came a CP angle
He has
big
got a
tumor.
left. On left gaze, there is a left beating nystagmus. Look right, sir. And if you observe on the right side, he has got a right beating nystagmus.
Very
So,
coarse,
right
very
gaze,
fine
right beating.
nystagmus.
Left gaze, left beating. So it's a direction changing nystagmus.
It's a Bruns nystagmus, you can say. And we did a MRI, and there was a big tumor. Fortunately, he got operated. Some funny nystagmus. There is no etiology in this case. Thank you very much for your listening and kindly accept my best regards. Thank you.
Thank you, Dr. Swanand. I request chairpersons to take over the proceedings. All my panelists, they have tried to finish in time. We are fully aware that further session people are waiting, so we will not be standing in between the way. I really appreciate efforts of Dr. Borade, Prasad, Dr. Harkut. They have taken a great efforts, and I'm very thankful to them for allotting time for a special Vertigo session, and of course the oration which we recently had some time back by Dr. Dora Sala. Thank you very much.
Thank you, sir. Now I request our chairpersons to felicitate our respected Dr. Ramesh Rohiwal, sir. Now I request our chairpersons to felicitate our all speakers. Dr. Rupali Jain, madam. Now we will go for the next session. Now I will call Dr. Charuhas Jagtap sir to felicitate our chairpersons. Thank you, moderator, all speakers and chairpersons. Now we will go for the next session, Deccan Branch Metcon Symposium, Allergy. May I call Dr. Praveen Bhosle sir and Dr. Gaurav Patel sir to be on the dais as the chairperson.